Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network, and I want to welcome you to our first lecture of 2019. It's January 9th, and this is an RN and Allied Health lecture. And so just a few things before we get started. If you're having any technical difficulties at all, don't wait. Call us, please, 919-445-1000. We do have people standing by who can assist you if you're having any trouble with the connection whatsoever. So I should mention that we're on the web at unccn.org. All sorts of information you can find out about both past programs and upcoming programs. We're on Instagram, we're on Facebook, we're on Twitter, we're on YouTube, lots of places that you can find us, and all of that information is also on our website. All right, we want to welcome to our series the Zimmer Cancer Center in Wilmington, North Carolina. We have several new sites we plan to welcome in 2019, but we'll start with Zimmer. So if you're out there at Zimmer, welcome. We're so glad to have you joining the UNC Cancer Network and attending this and future lectures. We'll be using Poll Everywhere for interactivity today. Very easy to use. We'll have a test question in just a couple of moments, and then there'll be questions where you can interact with our presenters throughout the lecture, and then at the end there'll be an opportunity for you to ask our presenters questions. So we really hope you'll take advantage of that. Two ways you can do that. One is using any browser on a laptop, on a tablet, on a phone, smartphone. You can just go to pollev, polleb.com/UNCCN. You do that, you'll see the questions come up. You can respond to them there, and then there'll be a field at the end where you can type your questions. That's probably the easiest way. However, if you don't have access to a browser or would prefer to text, you can do that as well. What you'll do is one time you're going to text in the to field, the number 22333, and in the message field, you'll type in UNCCN. Do that one time. It'll say, it will respond and say that you've joined, and then you can just respond with the appropriate letters or type in your questions at the end. Let's see what that looks like. So this is actually just a mock-up of but this is the question we'll be asking first. During the last 10 years in the U.S., about how much more likely are African American women to die from breast cancer than Caucasian women? And if you think that's about 10% more, you would put A, 20% B, 30% C, and 40% D. So we'll flash that actual question in just a moment. And so without further ado, I want to welcome Dr. Reeder-Hayes and Dr. Wheeler. Thank you both for being here today.
Thanks.
And let's see, we have a little bit about you in your bios. Dr. Reeder-Hayes, clinically trained medical oncologist specializing in breast cancer. And stop me if I get anything wrong. Research focus and comparative effectiveness of cancer treatments and cancer treatment disparities. Research interests on ongoing projects include the contribution of treatment variations and organizational characteristics to race and age disparities in cancer outcomes, and effectiveness of breast cancer treatment paradigms in elderly women, and adherence to endocrine therapy in breast cancer survivors. Is that a reasonable overview? Great. And what's one thing we should know about you that's not on the list there?
So when I'm not a medical oncologist, I renovate old houses.
Wow, wow. So we're going to look for a reality show soon.
That's right.
Coming your way.
I tried to sell that idea to HGTV, and they weren't interested.
Not yet. All right. Well,
House doctor.
There you go. Oh.
House doctor. Oh, yes. Yeah. It even had a cool name.
That's awesome. All right. Dr. Wheeler, Associate Professor in the Department of Health Policy Management at the UNC Gillings School of Global Public Health. And methodological skills encompass medical decision-making, mathematical and health systems modeling, health outcomes measurement, comparative effectiveness and cost effectiveness, and advanced ecometrics. Okay.
That sounds
on
right.
target, and I even had a chance to look up ecometrics, so I made sure I knew what that was, roughly. And what's one more thing we should know about you that wasn't mentioned
So when
there?
I'm not an academic, I play an actor on movies. And
Oh, wow.
So I have a small speaking role in the movie The Notebook.
Oh,
Yeah,
wow.
from years ago,
Wow.
like 10 years ago.
Yeah,
So
yeah.
if you're ever watching The Notebook, look for me about a third of the way in.
All right, very good. Good to know. Good to know.
Totally totally random.
That's great. Okay, so without further ado, let's take a look at our poll. And we've had several people answer already. Thank you so much. And how are they doing? It looks like we're heavily trending on answer D, about 40% more likely. Are they on target?
That's encouraging.
That's it. Okay. So we have an audience that's already very aware. It's discouraging. That's terrible.
Factual,
but people are aware already of what that discrepancy looks like. All right. So Disparities in Breast Cancer: A Biology, Health Services, and Solutions Story. And I will go ahead and pass this to you.
Thank you.
All right. Thank you so much.
So I'm going to talk for about the first half of our time together today, and then I'm going to let Dr. Wheeler pick up from there and talk about the second half. And we will be roughly focusing more on some biological factors in breast cancer for the first half of the talk, and some health services or health system factors that contribute to breast cancer disparities for the second half of the talk. So our objectives today, quickly, are first to do a quick review of the epidemiology of racial disparities in breast cancer and talk about which subtypes of breast cancer really have the biggest problem with the disparities by race. And then we'll talk some about tumor biology in breast cancer, which is not just one disease, but really a collection of different kinds of biology, and how that impacts racial differences among breast cancer patients. And then we'll talk about some of the evidence that disparities in treatment also play a role in differences in breast cancer outcomes, and in particular, the cost of treatment and how that interacts with race. And then finally, we'll finish by talking about something that Dr. Wheeler and I are particularly interested in, and that's moving from just understanding the different things that contribute to the problem to potentially starting to come up with some solutions. So I know I'm speaking to a mix of people who may treat breast cancer all the time, treat breast cancer occasionally as part of what they do, or perhaps not see breast cancer patients regularly at all. So I wanted to take a little pause at the beginning of this talk and talk about what we mean when we talk about a breast cancer subtype. So this is really our way of dividing breast cancer, which is very common, especially among women in their 60s, 70s, and 80s, into different types of tumors that tend to behave more similarly to each other. So historically, we've done this by looking at two kinds of receptors on the cell surface of breast cancer cells: the hormone receptors, which are estrogen and progesterone, and the HER2 receptor. So the most common kind of breast cancer is positive for one or both of the hormone receptors and negative for HER2. Overall, these tumors are the most common, but also have the best prognosis, which is one of the reasons that breast cancer overall is a very curable cancer. And the treatment usually includes what we call endocrine or hormonal therapies, which are drugs taken by mouth that in one way or another interfere with estrogen signaling and improve the chances of long-term cure of the cancer. In contrast, HER2 positive tumors, whether they also carry the hormone receptor or not, tend to be more aggressive, but fortunately in the last 15 to 20 years we've developed some very effective targeted therapies against the HER2 receptor that have really moved the needle significantly on the survival of this kind of breast cancer. And the foundational treatment is a biologic targeted therapy called trastuzumab. And the remaining tumors, which are negative for both hormone receptors and HER2 receptors, get the nickname triple-negative tumors because they're negative for all three markers. These tend to be biologically aggressive, and unfortunately we don't have a targeted therapy for this kind of breast cancer, and so we continue to rely on chemotherapy as the main medical treatment after surgery and radiation. So we're going to talk a little bit today about what we call the breast cancer survival gap. And essentially that's illustrated by this picture here, which shows that the total bar, the light represented by kind of the light teal bar, represents the incidence of breast cancer. And what this picture is telling us is that there's really not a big difference in how likely a woman is to get breast cancer in her lifetime based on whether she is non-Hispanic Black or non-Hispanic White will be the main two groups we're going to focus on today. However, if you look at the royal blue portion of the bar down below, that represents the chances that a woman will die of breast cancer in her lifetime based on her race. And you can see that that number is substantially higher for Black women. As we talked about in the first poll question, it seems that many of you are aware of this pattern and even got the right estimate of the effect, which is that a Black woman in this country is about 40% more likely over her lifetime to die of breast cancer compared to an otherwise similar white woman. And when we look at trends over time, they're somewhat troubling. And what I mean by that is that if we look at the graph here on the left, this is incidence, or the chance that a woman will get breast cancer in her lifetime. The line in green is non-Hispanic white women, and incidence has stabilized. The chance that a woman will get breast cancer in her lifetime among whites has stabilized in the last 20 to 30 years and even modestly come down with the declining use of postmenopausal hormonal therapy in the last decade or so. In contrast, among non-Hispanic Black women who are represented in the royal blue line, incidence has continued to rise, and as of about 2012, there really isn't a significant advantage to being a Black woman in terms of the chance that you will get breast cancer in your lifetime. In contrast, if we look at the right-hand panel, this tells us the story of a woman's chances of dying of breast cancer in her lifetime. Mortality has fortunately declined for all groups in recent years, but if you look at the green line, you see that mortality has consistently declined since the 1990s, most dramatically among non-Hispanic white women, and in contrast, mortality had a peak in the mid-1990s among Black women and has now fallen off some, but really is just getting back to the baseline that we saw in the late 70s to 1980s. And there continues to be this substantial gap, and when we talk about the breast cancer survival gap, the distance between those two lines on the right is what we're talking about. So this problem is not simple, and it's what I refer to as a perfect storm, because it's not just about one thing or one factor. So one of the things that we think about a lot when those of us who see breast cancer patients on a regular basis is the problem of advanced stage of diagnosis. So women who come in between screenings or without screenings with a tumor that's already gotten quite big in the breast. And if you look at the top panel of this graph from the SEER network of cancer registries across the country, you see that Black women in the blue bar are more likely than other groups to come in with regional or distant disease, meaning it's already spread to either the lymph nodes or the rest of the body, which reduces the chance of cure dramatically. And in the clinic, we tend to think of this as part of the race problem because it's what we see with our eyes. However, when you get down into the numbers, you realize that that is only really the tip of the iceberg. So if you break women down and compare them to other women with their same stage of cancer at the time they come into the clinic, you see that whether a woman has localized disease, regional disease, or distant disease, her chances of surviving 5 years from her cancer are lower if she is Black compared to other racial groups. Now, this is partly about aggressive biology of the disease, and we believe it's partly about access to care and missing opportunities for treatment in these patients. And those two things are really what we're going to spend the rest of the time today talking about. Access to screening and getting folks into screening is really, could be a whole separate hour, and so we will not focus on that today. So when we break this problem down a little bit by the subtypes that we've already spoken about, these are more data from the SEER National Network of Cancer Registries, we really see two problems emerge for Black women that are clinically relevant. So let's talk about triple-negative disease first. We see in this second panel here that the blue line representing Black women has the highest incidence of triple-negative disease. So as you recall, that is the bad prognosis subtype for which we don't have a targeted therapy, and it is more likely to occur in Black women. But it's important not to forget about the other part of the problem, and that's the far left-hand panel. And that is that Black women still have a significant incidence of hormone receptor positive and HER2 negative disease. And most of the cases of cancer among Black women in the breast and most of the deaths from breast cancer among Black women are still in this very treatable subtype. So we certainly need to focus on better treatment for triple negative disease, but we can't forget that most of the deaths from breast cancer in Black women occur in this hormone receptor positive subtype. So where is the disparity? In other words, where are the biggest differences between Black and white women with breast cancer in terms of how they do? So if we continue to think of this as a story that is about different subtypes, as we just said, this triple negative subtype is overrepresented, particularly among younger Black women, but the hormone receptor positive subtype is the one that's responsible for most of the cases and deaths. And if we look at how women with different subtypes of breast cancer do over time, we see that triple negative disease is almost a quarter of cases among Black women, as opposed to about 11% of cases among non-Hispanic whites, and that everyone with this subtype tends to be at high risk. 5-year survival free from breast cancer ranges in the 60s to 70%. And that is true regardless of whether you're Black or white. It's not a good disease to have regardless of your race. However, if we switch gears and look at hormone receptor positive disease, we see that it's still about 60% of the cases among Black women. And here we see a significant disparity. Disparity is the word we use to describe a difference within clinically similar disease that seems to be driven by something other than disease itself. So we see survival rates at 5 years in the 70s to 80s among Black women as opposed to the 80s to 90s among non-Hispanic whites. And that's what we want to dig into a little deeper now. So there have been various studies that confirm this observation, and they've come from all kinds of different data sources. So in the Carolina Breast Cancer Study, which is a large population-based study based here at the University of North Carolina, whether you look at City of Hope, which is a very large single institution cancer center in California, or even if you look at clinical trial participants in large national clinical trials, we see a consistent story, and that is that Black women with hormone receptor positive cancers have about double the risk of dying of that particular cancer compared to whites. And that is true even if we adjust for the things that we know tend to put people at greater risk: being diagnosed earlier in time, having more advanced stage of diagnosis, being younger, being obese, and even when we count for some of the factors that go into treatment, such as the type of surgery, the receipt of chemotherapy, and hormonal therapy, race still seems to be an independent predictor of a worse outcome in this breast cancer subtype. So when we see information like this, we start to wonder whether there is a biological difference that we haven't accounted for with the way that we understand breast cancer subtypes today. So historically, I wanted to show you some information from the Carolina Breast Cancer Study in more detail. There's a lot of information on this slide, but there are a couple things that I want to point out to you. So these are data from the first 2 waves of the Carolina Breast Cancer Study, which accrued between 1993 and 2006. And keep in mind that this was before we really had an effective biologic targeted therapy for HER2 positive disease. So if you look at the bottom of these curves, the worst survival curves, the ones that come on the bottom that represent the lowest chances of survival, you'll see that women with HER2 positive disease, regardless of their race, the HER2 positive patients ended up with the worst survival curves. But those survival curves were dramatically lower among African American or Black women compared to non-Hispanic whites. And similarly, if you look at what comes out on the top or highest survival curve, you'll see that the luminal A group, which is the equivalent in this model of hormone receptor positive and HER2 negative disease, does best in terms of survival regardless of race. But there's also a gap there in the luminal A's, with whites doing better compared to Blacks. And if we look at newer data from the Carolina Breast Cancer Study, phase 3, we'll see happily that HER2-positive disease among white women, which is the pink line here on the right, has moved up to a much better survival probability. So that curve has moved up and to the right, which is what we want to see with survival curves. And that, we believe, is the result of better biologic targeted therapy. However, if you look at the pink line on the left, you'll see that for Black women, HER2-positive disease still carries a very poor prognosis, and that those women are doing about the same as Black women with triple-negative disease, despite the fact that there's now an effective biologic therapy. And overall, it looks like in the newer years of the Carolina breast cancer study data that the gaps between Black and white women are certainly no better, and that they're probably a little worse. Although these are very recent patients and we're still following what happens to them over time. So why would this happen? Why would a survival gap stubbornly stay the same or even grow worse as treatment is improving? So we're going to talk about a little epidemiology just for a minute, and that's something called the fundamental cause theory of health disparities, first introduced by Drs. Phelan and Link in the 1990s. And that is the idea that if you're in an advantaged group, often represented by race in a given society, that advantaged group enjoys a lot of advantages and resources. And it may be financial resources, it may be educational or knowledge resources, it may be social connections that enable access to other better resources, such as treatment resources. And that package of things tends to protect a person or group's health no matter what treatments are available, no matter what mechanisms are available to make you healthy at any given time, that you have enhanced access to those mechanisms if you're in the advantaged group. So essentially, what that means is that if any disease doesn't have a lot of good treatment options, if there aren't any intervenable targets for that disease, outcomes are going to stink. Many people are going to die of the disease, but the disparities may stay pretty small. So for instance, prior to polio vaccination, there was a very high mortality for polio, and that mortality was really similar across different racial and socioeconomic groups because there just wasn't effective treatment to access. That's also true if you look at very old historical data in breast cancer prior to the 1950s. There really wasn't much of a pattern of difference by race. However, as different effective targeted therapies are developed, disparities would tend to widen according to the fundamental cause theory because those differences in resources and access to care start to matter more as the care gets better. So here are some recent analyses that we did in the Carolina breast cancer study. Again, this is a bit of a complicated slide, but the big story is very evident at the top, and that is that the overall group of Black women in the Carolina breast cancer study phase 3 in the red line is doing worse in terms of their survival at 5 to 10 years compared to the whites in the dotted black line at the top, and that while the curves look a little bit better in general on the right for women who are hormone receptor positive and HER2 negative, the gap's actually a little larger in this group than it is in the overall cohort. We did some modeling to try and understand what things may be driving this. If you do a model that just compares women with no adjustment except for their age, their risk is about double, which unfortunately is really similar to what we've seen historically. If we account not only for a woman's age, but for the stage and grade of her cancer, her receptors, and whether she got chemotherapy, we see a hazard ratio of about 1.6, which means about 60% more likely to have your disease come back in a way that is incurable. And then we started to try to incorporate some measures of biological aggressiveness, so some molecular markers that aren't accounted for by those clinical receptors we talked about. And we can bring the adjusted estimate down a bit. So as these hazard ratios fall, that indicates that we may be onto something in our understanding of what's accounting for the difference between Black and white women. So when we model something called the molecular subtype, which is a genomic measure that takes into account a number of different genes within the cancer, and RORPT score here is another way of measuring that genomic variation, we're able to explain some of the variation in outcome between black and white, although still not all of it.
All right. So with our first poll, which of the following statements is false? A would be African American women have less access to resources, money, knowledge, prestige, social connections, power, etc. B would be white women with HR positive cancer have double the risk of blacks. C would be the high risk triple negative subtype is overrepresented among young black women. Or D, HR positive HER2 negative subtype is responsible for most breast cancer cases and deaths among black patients. And we'll give our audience another 15 or 20 seconds to go ahead and respond. Remember, all of these are anonymous, so put the one that you think is most reasonable, the answer, and then we'll find out. All right. Well, we're strongly trending towards B. How are they doing?
And that's encouraging. I think that is the most true statement, the most false statement out of this, because we understand that black women actually with hormone receptor positive cancer have about double the risk of white women. It's certainly true that in some communities, African American women may have equal access to resources that are listed here. I think that's a little bit variable depending on the community, which is why a few people may have indicated A. All right.
All right. Well, thank you so much to our audience for responding, and we'll have some more questions coming up.
Okay, I guess I'm responsible for moving on. Right. So let's focus in some now on our hormone receptor positive patients, which again are the majority of our patients regardless of race. So why this big gap in hormone receptor positive disease survival? So really there are two main hypotheses. One is a biologic hypothesis. So let's imagine that the hormone receptors and the HER2 marker really aren't great ways of understanding all of the biologic differences in a tumor. They may tell us about some of the differences, but maybe there are differences that those markers don't measure. If so, and if some of those aggressive features are more common in black patients, we may not be measuring disease aggressiveness optimally in the clinic just by looking at hormone receptors and HER2. The other hypothesis is a health services hypothesis. If we believe that outcome disparities tend to increase as targeted therapy becomes more effective due to these fundamental barriers in healthcare access, then a targetable subtype of breast cancer might be a logical place to see disparities. So first, let's look a bit at the biologic hypothesis. This is some very recent work that we published about a year ago in the JNCI from Carolina Breast Cancer Study, in which we ran after this very question. This is led by my colleague Melissa Troster, and we took the tumors of only women with hormone receptor positive and HER2 negative disease, and we looked at what we call the molecular subtype, which is an expression of 50 different genes, so a more complex way of measuring biologic variability than just the hormone and HER2 receptors. And we saw by race that black women who we thought were hormone sensitive in the clinic were more likely to have a molecular subtype that we actually know to be relatively hormone insensitive. Molecular subtyping is not available clinically right now. It's only a research tool. But if you had to have a kind of breast cancer, you would optimally want to have luminal A, which has the best survival and which we usually tend to assume is the type of breast cancer that a woman with hormone receptor positive and HER2 negative markers has. But our guess that we make in the clinic that we use to treat you on a clinical basis as our standard of care is really more likely to be wrong if you're a Black woman. You're more likely to have one of these other subtypes which carry a poorer prognosis and may not be as sensitive to the kinds of endocrine therapies that we use as one of the cornerstones of treatment of this subtype. And if we break that down further by age and race, we can really zero in on the story of Black women under 50. So Black women under 50 had less than a coin flip, less than a 50% chance of truly being luminal A, even though if you had asked their physician to guess their molecular subtype based on the data that's clinically available, hormone receptor positive, HER2 negative, they would have said probably luminal A, and these women would receive endocrine therapy as a big part of their treatment. However, more than half of them may have subtypes that just are not that affected in terms of their recurrence risk by blocking the estrogen receptor pathway. So there is a commercially available tool that estimates some of this genomic variation with more complexity than hormone receptor alone. Some of you may be using the 21 gene recurrence score, which is the Oncotype commercial assay, to help women make decisions about chemotherapy after early stage breast cancer surgery. And if you have, this is something you're already familiar with, the concept of an Oncotype risk score. These scores run, technically speaking, from 0 to 100. Most of them are found between about 0 and 50. We did some work a few years ago here in the Carolina Breast Cancer Study to look at women who had already been Oncotype tested, and we found a slight suggestion in the red line here that Black women compared to whites were perhaps more likely to go into the high range of Oncotype score, suggesting a higher risk for recurrence and a greater need for chemotherapy, but these data were on a small number of women. Since our work, there has been a separate study in one of the large SEER registries in the Northwest looking at the Oncotype gene expression profile that confirms our concern that Black women, particularly Black women under the age of 50, are more likely to be where you don't want to be on an Oncotype score, and that's in the high-risk category. So that would be the gray bar here, and you can see in this bottom line of this graph from the Journal of Clinical Oncology earlier this year, there is much more gray if you're on the non-Hispanic Black side of this graph as opposed to non-Hispanic white, again indicating that within hormone receptor positive and HER2 negative disease, the kind of disease that we would often treat without chemotherapy and rely on endocrine targeted therapy, we are more likely to truly be looking at patients who need chemotherapy in our young Black women. So we're going to switch gears a little bit now, having talked some about the question of biology, to our health services hypothesis. And that is that maybe targeted therapy isn't getting to Black women as well or as often. So mine and Dr. Wheeler's research group here at UNC started investigating questions around this topic a few years ago. One of the first studies we did was to look at commercially insured patients in an insurance claims database, and just to ask the question of how likely they were to start endocrine therapy at an appropriate time after their initial breast cancer treatment. And we found a particular concern around women who had had a long course of initial treatment, including initial chemotherapy, which we know can cause a lot of side effects and be a difficult thing to get through. And also, these chemo-treated patients have some of the highest recurrence risks. And we found that in that group of women who had already had to go through chemotherapy, they were significantly less likely to ever get started on endocrine therapy if they were Black compared to white patients. So we've gone on to look at this in some more detail. We looked at behavior after initiation. So among women who had at least gotten one prescription for an endocrine therapy, we looked at their chances of being able to stick to the treatment plan, whether they continued to come back and get refills on that or any endocrine therapy medication over the next few years. And we found that young Black women were about 30% less likely to be getting those regular medication refills that indicated that they were sticking to their treatment plan. In contrast, for women over the age of 65, race didn't seem to make a difference in how likely they were to be able to continue to get those medication refills. And when we broke the patterns down even further, we found that young Black women more often had spotty adherence. They were still coming to get refills, but not often enough to indicate that they were taking the medication every day, as opposed to the pattern in white women, which tended to be either that you got your refills regularly or you just quit and didn't take the medication anymore. And I think what's significant about that to me as a physician is that if a woman comes in and I ask if she's still taking the medication and she says she is, I'm unlikely to pick up that she's maybe taking it every other day and not every day. And is that concerning? We have some work from colleagues around the country that tell us that it probably is concerning. So this is work out of Dawn Hirschman's group using commercial insurance data from Northern California. And she looked at women who either quit their endocrine therapy early or were spotty, non-adherent. They weren't getting refills regularly, but they did remain on at least some therapy. They were taking their medication some of the time. And we saw that in both those groups, there was a drop-off in survival compared to women who were fully adherent at 10 years. So that's certainly at least some preliminary evidence that goes along with our common sense that if you're skipping an effective treatment some or all of the time, we're probably going to see long-term effects on your chances of surviving your cancer.
All right, and we've got our next poll. And which of the following statements, again, is false? So which of the statements is false? A, Black women diagnosed with breast cancer tend to have more aggressive tumors and worse prognosis than white women. B, younger Black women are more likely to have triple-negative breast cancers and less likely to have estrogen receptor ER-positive cancers. Again, that's B. C is Black women under 65 are less likely to stick to their endocrine therapy adherence in studies shown. Or D, race was not tied to endocrine therapy adherence for women over 65 in the study shown. Or E, young white women more often have spotty adherence rather than quitting altogether. So which of those do you think is false? And we'll take about another 10 seconds. Give all of our audience members time to respond to this poll. Again, thank you so much for taking time to do this. And be thinking about and jotting down your questions so that you can use Poll Everywhere to share those questions when we get to the end of the lecture. All right, looks like we're trending on E. How are they doing?
So that's encouraging. I think most of our folks are still tuning in and listening out there. In fact, it is young Black women who more often have spotty adherence rather than quitting their medication altogether.
All right.
So we talked a little earlier when we were talking about biological differences about the idea that genomic testing that's currently commercially available, the Oncotype test, may be one way to pick up biologically aggressive disease in younger Black women, but the health access correlate to that is that in order to benefit from the test, you have to get the test. So one of the things we've done in our research group as well over the last few years is to actually look at the question of whether there are racial differences in who is getting commercially available gene expression profile testing. We published this in the Journal of Cancer about a year ago, and unfortunately we do see a pattern that we've seen many times before in cancer treatment studies, which is that among women who would qualify for the test, so women who are N0 or node-negative disease with smaller hormone receptor positive tumors, we saw that Black women are less likely in almost every year of data that we looked at to be actually getting tested compared to white women. And obviously it's very difficult to benefit from an innovative test even if it's available in the market if you don't get it. We also talked, when we talked about biological differences, about the increasing disparity in HER2 positive disease with our Carolina breast cancer study data suggesting that outcomes of this subtype have really improved a lot for white women but have not improved as much for Black women. And the health services correlate of that question is to ask whether women are getting HER2 targeted therapy when they need it. So these are data from another study we did in Medicare insurance claims, looking at the proportion of HER2 positive patients with Medicare who actually got trastuzumab, which is the targeted therapy that would be appropriate for their tumor type. And unfortunately, we see a familiar pattern now, which is that whether you were stage 1, stage 2, or stage 3, you were significantly less likely to get any trastuzumab if you were a Black woman. And I think particularly concerning to me as a clinician, if we look at these stage 3 women, they have a very high risk of recurrence at 5 years. So without targeted therapy, women probably have no better than a 50-50 shot of surviving this cancer-free at 5 years, and yet half of older Black women with HER2-positive disease and stage 3 disease, very high-risk disease, we're not seeing any trastuzumab at all, when typically our standard of care would be to give it for a year. And then the last slide I'll show before handing it over to Dr. Wheeler is actually from some earlier work by Dr. Wheeler during her dissertation, looking at the opportunity to receive radiation therapy, RT here, which is a standard of care after breast-conserving surgery for most women with breast cancer. And again, in Medicare data, she demonstrated that you were significantly less likely to get that recommended radiation if you were a non-Hispanic Black woman, here indicated in the reddish-orange line. So unfortunately, we have to say that there's a consistent pattern when we ask about access to innovative treatments, appropriate treatments that are recommended by guidelines, whether we look at local therapy, targeted therapy, or the receipt of gene expression profiling. And now I'm going to hand it over to Dr. Wheeler to talk about some more of our disparities data that's more talking to patients directly about what's happening to them and their experience, and then some of the things we're starting to move into with interventions to help solve the problem.
All right. Thank you, Dr. Reeder-Hayes, and thanks to all of you out there listening today. So I think Dr. Reeder-Hayes has done a really nice job of presenting the biological contributions to racial disparities in breast cancer outcomes, and also the treatment level disparities that we see in our practices. And so one of the things that I want to do is to get into more detail about the reasons for that. So Dr. Reeder-Hayes presented a lot of data about the importance of endocrine therapy related to hormone receptor positive disease. And what we have seen consistently across our studies and others is that endocrine therapy is not as often received by Black women. And as Dr. Reeder-Hayes noted, a lot of that problem seems to be an inconsistent use of the therapy. So one of the things we wanted to understand in the Carolina Breast Cancer Study follow-up data is what are the reasons that contribute to that non-use of endocrine therapy. So in doing that, we surveyed our patient populations in the Carolina Breast Cancer Study Phase 3. We asked them a couple of questions about the consistency of their use of endocrine therapy. And as you can see here, by 2 years post-diagnosis, 1 out of 4 women were non-adherent to their endocrine therapy, which is characterized by either an incomplete pattern of use or full discontinuation, compared to 17% of white women. And as you can see here, and as Katie has noted in other studies, the rate of discontinuation was similar across both white and Black women, and really the issue seems to be an inconsistent pattern of adherence in Black women. So we asked a lot of questions about why this might be happening and asked women to self-report their reasons for non-adherence. And I think what's really striking across these questions is that there's not a single reason why women are reporting this non-adherence. In fact, across all of the reasons that we explored, which were really theory-driven in the behavioral science literature by other studies that have looked at medication adherence, we found that Black women more often were forgetting to take pills, expressed difficulty with sticking to the treatment plan, missed pills due to cost, which we're going to go into more detail about, missed pills due to the refill requirements, and had concerns about long-term medication use. And overall, Black women reported more ambivalence or feeling neutral about the benefits related to the potential harms of endocrine therapy. We also asked about the perceived risk of recurrence. So motivation to take any medication is really important. And one of the things we see here in these questions is that, first and foremost, Black women were more often reporting that they felt they had a very low chance of their cancer coming back. And then when we asked, what do you think would happen to that risk if you do not take your endocrine therapy pills as prescribed, if you go all the way to the far right side of the screen, Black women more often reported that they didn't really feel like their risk changed at all. They were twice as likely to say that. So this motivation could be an important mediator of the decision to not take medication. In addition, we looked at a range of side effects that might be experienced by women taking this medication. And I think it's really striking that across all of the common side effects that are reported among women taking endocrine therapy, Black women more often across the board reported these as problematic for them. So they were saying they experienced these symptoms more often than did white women. When we put all of these factors into a multivariable model and really try to understand what are the main contributors to non-adherence in this population, and there's a lot of data on this slide, which I appreciate. I want you to focus your attention all the way at the bottom of the slide, which the two measures of recurrence risk perception here were the things that came out as the most important factors that were associated with non-adherence. Also important is, if you look at the top of the slide here, there's still a statistically significant effect of Black race, even when we control for all of these clinical factors, as well as the extent to which it was a shared decision between the patient and the provider to take the medication, as well as the motivation. So I want to transition a little bit to the financial aspects of this. So one of the things I said a minute ago is that Black women were twice as likely across the board to report a whole host of reasons why they were non-adherent. One of those reasons was that the cost of the medication was too expensive for them to afford. And this is one of the things we've really zeroed in on in recent years. So I think probably everyone is aware that the cost of cancer care is alarmingly high and continuing to increase, with a lot of that concentration of high healthcare costs focused in the cancer drug setting. So this is a concern for us as public health and clinical providers, because the rising cost of cancer care has very real implications for patients' health. We know that skipping medications can lead to a lot of poor outcomes, including anxiety, stress, depression, worse quality of life, and skipping medications due to cost specifically. In addition, when the cost of cancer care is high enough, it can certainly lead to, on the individual level, a lot of medical debt, inability to acquire loans and to pay bills, both medical and non-medical. And in some rare cases, it leads to medical bankruptcy. And in fact, this is one of the highest reasons, or one of the most common reasons why people declare medical bankruptcy is the cost of their cancer care. So in our data, in the Carolina Breast Cancer Study data, we really tried to understand both the post-diagnosis experience of the financial impact of cancer, but we also needed to understand how financially vulnerable this population was at baseline, because that's an important predictor of financial outcomes. And at baseline, we do see that Black women had lower household incomes overall. They were more likely to be uninsured or publicly insured and less likely to have private insurance. When we looked at the financial impact of their breast cancer 2 years post-diagnosis, we looked at a range of different indicators of potentially adverse impact of cancer. And we see across the board that Black women are more likely to report a decrease in income, a financial barrier to care that led them to forego or delay care, a transportation barrier to care that led them to forego or delay care, losing their job as a result of their cancer, and losing private insurance as a result of their cancer. And when we look at all these things together in a composite measure, which is here on the far left side, we see that about 60% of this patient population, 60% of Black patients, reported any adverse financial impact post-diagnosis, compared to about 40% of white women, which is also a very prevalent problem in our white patients. And then again here, when we look at multivariable models where we control for things like baseline financial status, marital status, which can be a protective mechanism against financial shocks. When we control for all of those factors, including receipt of different types of therapy, stage of disease, we see a persistent effect of race in explaining some of these outcomes. And so that's there on the far right model. These are a couple of different models that are adjusted differentially by these potential explanatory factors. Oops. So we have another poll question.
All right. And so which of the following statements is, again, this is false. Black women were more likely to report mistaking ET pills due to cost. That's A. B. Black women with breast cancer are more financially vulnerable than whites at diagnosis. Again, that's B. C. White women reported experiencing more ET-related side effects than black women. C. And black women with breast cancer report worse financial impact of their cancer at 2 years post-diagnosis. D. So take a few more seconds. Go ahead and indicate which answer you feel is correct from the four, or is false in this case, of the four of these answers. All right. How are they doing?
Looks like 92% of people get an A+.
Great.
So it's the opposite. Black women report more endocrine therapy-related side effect burden than do white women.
All right.
Okay, so one of the really important things that we think about, Dr. Reader Hayes and I, is how to intervene and how to really try to shift this unfortunate trend towards something that we would feel more comfortable with as public health and clinical scientists. So we've given a lot of thought to this particular area. So in terms of trying to move the needle on disparities more generally in cancer care, there are a lot of techniques that we really can use and that are at our disposal and probably not used nearly enough. Most of these need to be multi-level in nature to really address barriers at the patient level, at the household level, at the provider and practice level, as well as at the health system level and the community levels. So these things are all acting in concert to really contribute to disparities, lasting disparities in cancer outcomes. And so we think all of them need to be addressed in important ways. We've done some work looking at the use of motivational interviewing to try to improve some of those risk perceptions and underlying patient motivation for things like adherence behavior. We also have done work around using financial counselors and monitoring for financial risk in our clinics. Really thinking about the diversity of settings and the capacities that they have locally is essential. We've also done work looking at behavioral economics and really trying to change the choice environment to make it easier for patients and providers to do the right thing. And I don't want to suggest that there's blame to be placed on either of these parties, but rather sometimes in the clinical setting, which is a very complex set of realities, we need to make it easier for things to happen as they should. As well, we've looked at preferences and social support networks and ways in which we can leverage mobile technology. So one of the things that we're doing now is testing an intervention that we call Get Set, and this intervention is really focused on the adherence behavior to endocrine therapy specifically. We've spent about 2 years designing and delivering this intervention in the UNC healthcare system, and we're in the process now of hopefully scaling that up to other practices in the next couple of years. And so what this intervention entails is several elements, including an introductory video for patients that talks about the importance of endocrine therapy and what it means in terms of risk of recurrence. We offer 5 motivational interviewing counseling sessions with a trained counselor. And the intent of these sessions is really trying to work one-on-one with the patient to understand the patient's goals of treatment, patient-specific barriers, and to do problem solving and to really help patients in a very directed and patient-centered fashion to come up with their own solutions and techniques that could help. We also provide an evidence-based workbook and resource guide that can serve as support for women taking endocrine therapy. One of the things that is in that resource guide and one of the things that's discussed at length in the counseling sessions is the financial aspects of treatment and having a plan and being prepared, and when there aren't sufficient resources either in the form of healthcare insurance or asset reserves within the household, linking patients to medication resources that can provide copay assistance or that can provide medications for free. So when we think about preventing and mitigating the financial burden specifically, and this is beyond just the endocrine therapy treatment experience, but for all breast cancer treatment, we think about this in a couple of different ways. One, we need to be more thoughtful about preventing financial risk, and so this really requires systematic early identification of financial risk in all of our patients. We can't make assumptions about who has resources to afford their care, and we can't just make assumptions about the utility of insurance to really cover that shock and to really cover the full cost of cancer care. So this needs to be something that is really systematized in all of our clinics. We also need to think about treatment of financial burden when it occurs. And so there's some good evidence that has started to emerge about the use of financial navigation. Many of you are probably familiar with clinical navigation of your cancer patients through surgery and chemotherapy and radiation. Financial therapy or financial navigation is very different because it's targeted to barriers that are financial in nature. And as a result, the solutions that are most appropriate to those barriers are very different than what most clinicians are familiar with, and they're much more in kind of the social workspace and can include a variety of different mechanisms and resources that may really address patients' needs. Also, we think that there's an important role for simplification and coordination of the processes that are involved in understanding and mitigating financial risk. We've talked a lot in our team about a universal or a common application for resources that are financial in nature because, frankly, the current system is quite fragmented. There are copay assistance programs through foundations, through hospitals, through churches, as well as a number of non-medical assistance resources that can be extremely difficult for patients to navigate on their own, and certainly difficult for clinical care providers to navigate on their own as well. So we need to spend a lot of time collectively trying to warehouse and understand how to link patients more effectively to those existing resources. One of the things that we've done in recent years is ask cancer care navigators, so these are clinical navigators in our oncology practices, if they could make one improvement to the system related to the financial aspect of care, what would it be? And the two most common reported improvements that this group suggested is using financial navigators as a part of the multidisciplinary care experience for all cancer patients, as well as having more provider communication and assessment of financial risk. So I think that that underscores the importance of intervening meaningfully. As I mentioned, part of the problem is the fragmented nature of all of this and the lack of coordination. This is a process map that describes actually UNC's system in terms of how patients are accessing financial assistance. And I certainly don't mean for anyone to read all the various aspects of this process map, but I want you just to imagine for a minute that you're a cancer patient trying to navigate the clinical aspects of your care, and you know that you don't have sufficient resources to do that, and you have to make it through this system on your own. It's a problem, and it's something where we can do a lot of work to simplify and again, more meaningfully and effectively get patients to the existing resources that we have in our various clinical environments. So how we're doing that now is a dedicated needs assistance program that will first assess patients' financial risk, put them into categories, and then navigate them directly to the resources that are most appropriate for their care. And I'd love to answer any questions about that if people have them. We'd love to see this model replicated elsewhere. I think it is probably the only way right now to deal with this complexity of financial risk in a helpful way for patients. So I just want to conclude with a statement and a challenge. Unfortunately, the disparities literature is rife with plenty of evidence that disparities among Black and white women in particular are widening over time in cancers that we know are treatable, like breast cancer for the most part. And this is really a call to action for all of us to take this seriously and to really think carefully about how to change practice and how to offer the resources that do exist to the right patients at the right time. Otherwise, we're just going to continue to see these inequalities in care, inequalities in access persist. Thank you so much for your time. I think we have a minute or two for questions, not much time.
We do. We've got just a couple of minutes, so thank you both so much. Let's see if you can pass back the keyboard. I'll go ahead and put us on the slide where we can take those questions. There we go. All right, so this is an opportunity. Please use Poll Everywhere. Please either via the texting mechanism or via the website. Go ahead and share your questions now. You can go to pollev.com /UNCCN. knowing this disparity exists and having the data to support it, why do you think there has not been a change in practice and policy, specifically TAR, and I'm guessing we're going to see that. We can kind of guess what's going to be there, but hopefully there's a character limit, so if the person who shared that will share the rest of that question.
So I'm not sure I can explain or justify U.S. healthcare policy.
Mm-hmm.
Interestingly, I think disparities have not been a big part of the national conversation about health policy and changes in access to health insurance over the last few years. There may be understandable political reasons for that people who are advocating changes to the health insurance system may want to make that an issue that's salient to everyone.
Mm-hmm.
But when the system doesn't work well, unfortunately, it tends to work the least well for the most vulnerable patients. And so I think that's a question that may be a little beyond my scope. In terms of changes to practice, I think one thing that we can do on the research side is to have better integration between the public health researchers and the clinical researchers, and therefore also the clinician audience. So when we published our trastuzumab data, our HER2-positive breast cancer disparities data, that was published in a clinical journal, the Journal of Clinical Oncology, that's probably the most widely read journal among oncologists. And I had many interactions with people at national meetings who were stunned by those data.
Mm-hmm.
I wasn't stunned by them. I see that pattern of care all the time in cancer, but that was a new message. People had not thought about it. And so I think one of the things that we can do better as researchers is to get the message about the patterns that we're seeing out of just our academic, enclaves and out to the people who are making the frontline decisions, because we don't believe that anyone in healthcare who's out there treating cancer and trying to make people better is deliberately making decisions or setting up their practice or their health system or their hospital in a way that tries to give better care to some people than others. These are systems problems. But I think the first step to fixing them is being aware of them, because then that results in people going back to their own healthcare system or hospital or practice and thinking about, how could I change the system here so that it's easier for certain patients? And so I think awareness is a first step.
Thank you. Dr. Wheeler, you mentioned the Get Set program. Is that something that somebody listening today could find out about and potentially implement at their site?
It's a great question. So we have just concluded our initial pilot study, so the recruitment for that is closed at this point in time. But Dr. Reeder-Hayes and I are encouraged by our recent score on an R01 submission that would scale this and extend it and adapt it potentially to other sites and settings. And so if you're a member of the NCORE network or an Alliance site, those are some of the places that we're starting our recruitment or planning to start our recruitment within the next year. But feel free to email either one of us if you're interested in learning more.
Thank you so much. We'll take this last question because I know we are going over time. Have you seen differences in treatment like you discussed in the presentation, RT and HER2 treatment in comprehensive cancer centers versus smaller or rural centers?
You want to take that one?
Sure. So there has been some evidence dating back a little bit further about radiation therapy use specifically in rural settings and showing non-comprehensive cancer center settings and showing less likelihood of receiving guideline concordant treatment in some of those smaller settings. I haven't seen anything in the HER2 setting specifically, but one of the things that I'm interested in, we're doing some work in right now, is looking at the financial experience, which is another outcome that the audience member didn't particularly raise. But we are seeing higher risk of poor financial outcomes in rural patients, and in particular, rural white and black patients. So it seems that white urban patients are most protected against financial risk relative to other groups. And so we are very interested in the rural experience and really trying to explore that further.
And I think as a clinician who interacts with physicians and oncologists around the state, I think there's so many things about the practice environment in smaller areas, in rural areas with a big catchment, that make it very understandable why it's hard to deliver cancer care here. So I definitely don't want our work to ever send out the message that providers who are out here in these places where there's great need, and where most of our patients get their care. Most of the cancer patients in the United States get their care at a community cancer center. We definitely don't want to ever send the message that someone is making bad decisions or delivering bad medical care. This is really about being in a challenging environment and about the whole healthcare system figuring out how we can make it easier to deliver the good care that people want to deliver and that patients want to receive in these challenging environments, from a transportation perspective, from a financial resources perspective, from a socioeconomic perspective in terms of the patients who are walking in the door.
Thank you both so much. A few things I want to go through very quickly. Upcoming live lectures, January 23rd at noon, Best of ASH 2018. Myeloma and leukemia, MDS, with Dr. Reeves and Dr. Foster. Then on February 13th, safety considerations when managing dietary supplements in cancer care with Jacob Hill. So we'll look forward to having you hopefully for both of those. We have more self-paced courses online now available, aerobic and resistance exercise in cancer patients, methods and benefits with Dr. Bottiglini and Dr. Wood, and understanding oncology drug interactions with Dr. Morgan. You can go to the learning portal and take those on your schedule and receive credit for those courses. Thank you, Dr. Wheeler. Thank you, Dr.
So
Reeder-Hayes. We really appreciate it. Thank you all to all of our audience members for participating, and we'll see you next time. Absolutely.
do that
We'd be
outreach.
happy to. And
It's very educational in nature,
Yeah,
which
yeah.
is in the spirit of this.
Yeah, no, that would be great. We'd be
Better
happy to.
than a Zoom meeting from
Yes.
your office.
Oh,
And
Your
this was
laptop
actually
camera.
Zoom at the heart of all of this.
Is it?
And if you don't have Zoom accounts, they're all free and campus-wide now. So if you need any
The
training
point
on
being,
Zoom or anything,
it's better than trying to position the laptop cam and make sure your
Right.
jacket's not
Well,
hanging over the
and
back
since
of
you
it.
guys have support staff who run these systems
Yeah,
and stuff,
yeah.
that would be helpful as opposed to me trying to do a Zoom teleconference. That's basically, I had a bad experience yesterday. I wasn't running it, but I was a speaker for a webinar, a national webinar, that was just poorly organized, and they had some technical glitches, and yeah, so it'd be nice to have people know what they're doing.
But everyone was wearing pants.
Yes, everyone was wearing pants.
Dr. Wheeler swears that she was once a part of a large study section virtual meeting in which 2 people were not wearing pants and did not.
Not proper pants. They were wearing like boxer shorts.
So we're not aware that their cameras were not off.
Okay.
Dangers of working from home, right?
Super.
Right.
Hopefully they were working from home. They were wearing boxer
for sure.
shorts.
But do y'all have like any boilerplate about the systems here, like description of kind of what you do, and
Like they could be put into a grant
it could be put
application.
into a grant to describe
We
this?
can come up with something
Okay.
for you. We've certainly done that previously, and so we can come up with something. So
Okay.
just for that, just correspond with me and let me know,
Great.
and we'll put
And
something
then
together.
could I ask for a letter of support that sort of
Yeah.
describes your willingness to help
Yeah.
us with
No,
that?
we've done that before, and we'd be
Okay,
happy to
great,
do that as well.
great. It just occurred to me as I'm sitting here, I'm like, this, I've been here before, but
Yeah.
I had forgotten just how nice this was.
Well, good. Yeah, the studio, outside of these lectures, we don't have a lot of use of it, and we'd love to see it being used more. And
Yep.
again,
Terrific.
this is all UCRF funding, so yeah.
That's awesome.
Absolutely. Okay.
We could also think about, as it gets revved up, if we wanted to at least do one like site PI meeting
Yeah.
with our first 20 sites from here. That might be cool.
Or if you have things that you want to record, you can just come in and sit down and hit record and have your video, your slides, your audio all, and then we can hand that off to you as a link that you can either go to our site where we can put it in our library, or you can embed it in your site as well, and it's easy.
Because
That's
every
a really
time
good
somebody's activated, we're going to have to do a startup.
Yeah, so we might as well just record it and do
Yeah,
the
exactly.
same thing.
Yeah.
Perfect. Well, thank y'all.
Okay,
Just to
good.
double check, Tim mentioned assessment. Double check on that.
I did not.
Okay. The last step in this is that we will take the recording and put it in our learning management system, learning portal, so that people can use this to get continuing education credits for another year.
Okay.
And so I will write the assessment and then
Okay.
ask you to just look it
Sign
over,
off on it.
make certain it's okay.
Perfect.
Make
problem.
any changes you want.
Make sure it's
Okay. Yeah, that sounds good. No
Okay.
problem.
Great.
Thank you very much.
Thank you.
I got a good picture. You were talking about the notebook. We stayed in we rented some cabin once on a lake for a week, and they had the bathtub, the clawfoot bathtub from the notebook. So I got a really goofy picture of my son
That's hilarious.
in a wedding veil.
That is hilarious. Yeah, when I was in school in Charleston, where they filmed the movie, when they were doing it, they were looking for like extras and stuff, and somehow I ended up with a speaking role.
Oh, good for you. Wow.
And then when the movie came out, like at the time I didn't really appreciate how big of a deal it was. And so I still get royalty checks.
Wow.
And in the past
Wow.
month, I've gotten about $120 in royalty checks from that
Wow.
movie.
Wow.
It's just hilarious. I have just random checks that show up at my
good for
house.
you. And I sent you the information on the radon mediation.
Oh,
so,
thank you.
Yeah, they were really good.
Thank you.
And I had no idea where to start with that. And I had bids triple that for actually saying they would do less work. So the price seemed really good on that as well.
That's super helpful. Thank
Yeah,
you.
yeah.
Well, this was very timely for radon mitigation and for this grant I'm writing.
Yeah.
You should come over here more often.
I'm looking for that house doctor show to come.
That's
out.
right. I know.
Yeah.
Each in my spare
TV
time.
house doctor. I love it. Thank y'all.
All right. You guys have a good afternoon.
All right, you as well. Thanks both so much.
Yeah, so
Are you heading back to the clinic?
yeah, well, back to my office, but I'll
Oh,
probably
yeah,
go to the
that's
hospital
beautiful.
and here and eat. Yeah, actually, one of my best friends in Gilead, they bought a house across the street from them, like a little house that they're actually planning to renovate it and live in it for a little while while their own house is getting renovated and then rent it out, like.
So I just want to make sure you understand that I really do appreciate it. It really was good.
You're so gracious.
That makes you, we hope that makes your interaction with the next 10 people more fun.
It is. It actually is.
Yeah.
So,
Thank you.
thank you. And good luck.
Thank you.
So I'll remind her about that because I really, in general, because you actually cannot mute when Zoom is ended because the codec has a control function. So I'll go ahead and end this. But apologies to anyone.